Thank you so much.
Thank you so much, Porshika. That was super helpful. Just a quick opening up, any group announcements or community shout outs related to any other events that we may have left off our list, or other announcements you'd like to share in D&I Science. Pause here for a moment. All right. I think I'll move us along, but feel free to drop anything in the chat if it comes up, just in the interest of time here. All right, so to kick us off, we have Dr. Jonathan Scacia. He's the principal of the Dawn Chorus Group and co-founder of PubTrawler. He's a community psychologist and evaluator with over 20 years of experience working in community-based settings. His career began as a substance abuse counselor in North Philly. He has extensive experience helping organizations select, adapt, implement, and evaluate community-based improvement interventions. Dr. Scacia was one of the initial developers of R=MC², the readiness model. His current research focuses on developing comprehensive methods to evaluate quantitative and qualitative differences in organizational readiness and enhancing strategies that can help to build readiness. Then I'll introduce the subsequent speakers as well, just right here in the beginning. Dr. Susan Glockner began her association with UCSD in 1985, enrolling in med school when eucalyptus groves greatly outnumbered buildings. After finishing her family practice residency in Santa Monica, she completed her primary care sports medicine residency at UCSD in 1992 and spent over a decade as a partner in a small practice in Encinitas, a suburb of San Diego. And her desire to serve those in lower resource settings led to working in community clinics for nearly a decade, and more recently to solve upstream problems, and started her MPH at UCSD last year. She's on volunteer medical faculty at UCSD student-run free clinic, merging her passion for nutrition and exercise with her work on Dr. Sarah Linke's Exercise is Medicine program. And we have Dr. Sarah Linke joining us today, who's the current Senior Director of Health Economics and Outcomes Research at Omada Health, and an Associate Clinical Professor within the Herbert Wertheim School of Public Health and Human Longevity Science at UCSD and the Department of Family Medicine. Dr. Linke's research is focused on developing, evaluating, and scaling health promotion and behavior change programs. And for the past 5 years, Dr. Linke has led the implementation and evaluation of this Exercise is Medicine program, which we're going to learn more about, within primary care clinics at UCSD Health and the Student-Run Free Clinic. This research was funded by an internal pilot award and a career development award from AHRQ. All right, without further ado, I will pass it over to you, Dr. Jonathan Scacia, and if you can share your screen.
Sure, yep, I guess.
And we should have time for some questions after, before passing the reins off to our other presenters. Jonathan.
What a thrill. It's one of like 3 times a year I get to be called doctor. It's wonderful. So yeah, hey, so I'm John Scacia. My background's primarily in community psychology, and that's the perspective I bring to this. You know, basically, for those who don't know, community psychology is sort of like an offshoot of prevention science and social psych. And basically, we work with people and systems trying to get good ideas into the places and where we live, whether it be organizations, communities, and the like. And, you know, naturally, you know, I got really attracted to implementation science back in grad school, because it's all about that, getting the good ideas out there. So over the past, you know, I guess I've been involved like in implementation science for like 15-ish years. You know, there's been a lot of different levers that I've been able to press when working with these organizations, you know, training, technical assistance, fidelity monitoring, applied evaluation, all that cool stuff. And there seemed to be something particularly amenable to a technological solution, and that occurs way back at the beginning, and that's in the synthesis and translation process. So, you know, whenever we publish an article, you know, whenever we toss something out there, what happens to it? And so, you know, it's like a shibboleth that there's a 17-year gap. We blah blah blah. We know that. Everyone can quote that or has it tattooed. As a consequence, we know the best knowledge is not getting out there. So our students may not have the most current knowledge. Industries are not aware of current developments. And really, really critically, patients may not be aware or may not be getting the best possible treatment. And we know from talking to a lot of actual practicing frontline physicians, how do they spend their time staying up to date? There are little things here and there that people use, little software and subscription services that purport to provide people best practices, but people are super busy. How long is your article reading list? Mine's probably about 150 right now, and I don't make a dent in it at all. And then the question becomes, well, how much time would you want them to spend up to date? So if you had an appointment with your gastroenterologist, would you want them to know that they're pretty current with the literature? And that's really just what we put together here with PubTrawler. It's just time to understand the research a little bit better. So we wrote this web-based tool that pulls from the public literature and applies a series of natural language processing techniques to cluster, organize, and summarize what's out there. Now, we're not doing meta-analysis. We're not extracting data from tables and then weighing findings accordingly. I want to do that eventually, but that's a couple years off. What we're basically doing is providing an organizing structure on what you get back. So if you were to search in PubMed, you're going to get a list of articles ranked by, potentially their citations. That's what Google Scholar does, or some other type of metric. We're getting more into the semantics about what the articles are saying and trying to put that organizing structure on top of it. We wrote sort of a backdoor publication about this last year. My colleague, Victoria from North Carolina, Charlotte, where we basically took everything in implementation science, the journal, and said, well, what's it mean? So we pooled all 1,700 articles and tried to cluster them and see if we could identify trends over time. And what do you know? Systematic reviews are becoming more important, and we've moved forward since then. Here's just a topic cluster on harm reduction research. This is maybe about 4,000 articles clustered in what they're about. And really, we see this as a way to help focus people's research questions. This is a high a highly qualified audience that I'm talking to. So we know that you have, oh, what happened there? We know that you're going to have to read the articles if you really want to understand them. That much is clear. And if you're searching for something like autism treatment, like I did here, you're going to get the phone book back. And even when you're using some more precise types of search engines like JSTOR or the Public Library of Science, you're still going to get huge amounts back. And either you or your research assistant is going to have to screen them at a cost of, well, if you're paying them a little bit above, if you're paying them $17 an hour, it's still going to cost a lot. What we do is we take those results, and through their semantics, we try to reduce them down to what are the things that are most representative. So I can sort of show you what this looks like. PubTrawler is a live website right now. So if you go there, PubTrawler without an E because it's stylish.com, you can search for anything off your heart's content. If you all do it at once, it's probably gonna slow the server a bit, but there's a lot that we sort of pull back. So I just had some stuff prepared beforehand. So this is something I searched for right before we started: social media and violence prevention. So this is the free level or the quick level. So this pulled back 65 publications, identified the review articles, the journals that are publishing most frequently on this, being able to provide all the results, and then showing some sort of real small visualizations on it to help sort of make sense of what the macro themes are. So stuff about suicidal ideation and so on. When we're able to bring more articles into this, we get more exciting stuff. So a couple days ago, I was like, well, we implementation scientists, we love our frameworks. Everyone loves frameworks. So I searched for, implementation science and framework and got, close to 4,000 articles back. That's a little too much to work through. A buddy of mine, when I started in grad school, did a synthesis of implementation frameworks. I think he worked with like 19 of them. Well, he would still be in school now if he did that work now. So what we do is we take these 4,000 articles, and we through the words that they use, we cluster them to identify what they're talking about. And what's really, really cool is we then summarize those topics based on what's in their abstracts, and find an article that's most representative of them, most representative of that topic. So we've effectively taken those 4,000 articles and reduced them down to 25. So yeah, there's information loss there, but if you're really doing deep work into implementation frameworks, you're not just going to use us. You might use this to sort of get a sense of what's out there and the topic areas in which stuff is being published. This just shows all of the articles and how they relate to one another. And then something that we're really, really keen on is these 101 days of science, which are these curated lists that pool on specific topics for the last 3 months. So as a community psychologist, I like to try and stay abreast of the literature. If I were to try and keep track of these journals where community psychologists generally publish, 740 articles have happened since, I guess, was that mid-October. So the same type of thing, we provide some visualizations and some clustering of those topics to help put some meaning on what's there so that we know where to focus our efforts if we're trying to be strategic with our limited time. So the size of the circle corresponds to number of articles, and this spacing is actually meaningful. This is a technique called UMAP. It's a dimensionality reduction algorithm. So like articles in topic 12 and topic 23 are more closely related than ones in topic 18. And we then do the same thing. We provide summaries of what's in those topics along with an article that's potentially the most representative of that. And then we also provide all the results that you're able to export and then use to your heart's content. We also like to just scan the news to see what's out there. So on community psychology, we do see some stuff on mental health, and it's like power, vice president for some reason, and then do another technique to see what's sort of the emotionality of those articles. I'm getting too into the weeds now, so I can just go back to the slides. So we work with a bunch of different people, primarily to help them make sense of the data, help them make sense of sort of large swaths of literature so they can apply it in various either prevention activities, learning activities, or patient advocacy activities. If you want to teach your patients and their stakeholders what's coming down the pike, this is a good method. So there's a bunch of people working with us. Rohit's probably the most familiar face to this group. Rohit's an implementation and improvement scientist, and we talk a lot about how do we improve the quality of sort of the application of our results. And we're still doing a ton of work from like an algorithmic perspective, trying to improve the quality of what comes out. So anyway, that's PubTrawler. If you want to register an account and use like the promo code Thought Leader, you can get 101 days of implementation science for free for forever. We're really interested in improving this because going all the way back to like the first slide with that 17-year gap, there's a lot of stuff that still has to happen, even when you get past that synthesis and translation stage. So we're interested in what does it take to make the science less intimidating and more approachable? How can we get people to begin to think about, oh, I can go to the primary literature and get a better sense of what's out there and inspire them to explore further. We also have a blog that we update really regularly, and we're always looking for guest writers. So if you have something to say that doesn't rise to the level of putting it in a journal, hey, we'll probably buy it and promote it and publish it for you if you'd like. So any, I guess, do I have question time now, Claire, or?
Yes, you have about 5 minutes of question time.
Okie dokie. Any comments or questions?
If no one else wants to ask a question, I will. My name is Jessica Aaliyah, and as someone who writes guidelines, I find this really fascinating and interesting. And my question is, when you select an article that you consider most representative of a topic, what goes into that selection process, and how do you kind of determine, is this not only representative, but is it kind of like, is the methodology appropriate? Did they, did they analyze the data properly? Like, is it representative, and is it a quality article as well?
So there's sort of like two aspects of that. It's one, how do we like internally determine sort of like the quality of the article? And I know that there's like many different sort of like systems to use for that. And we don't apply that yet. We're not scraping from like predatory journals. We're scraping from PubMed, and soon we're going to scrape from Archive and ERIC. So there's sort of like that pre-screening that goes into it, but we make no statements about the methodological quality of the article, mainly because I also don't want to get into the doing health recommendations yet for liability reasons. We just want to provide the information. In terms of the representativeness, though, that comes from a specific natural language processing methodology called latent Dirichlet allocation, where you basically assign based on the clustering of words and the way those words relate to one another, you assign the probability that that cluster or that string belongs to a specific clustering. So what we basically do is, once we get that list of, in this case, 1,400 articles, we say what article had the highest, in this case it's called the gamma parameter, so that it's most likely to be representative of this particular clustering. Now, you also allude to, I think, what's really important, and that's the need to have like a human in the loop. And a lot of systems still do rely on that human in the loop phenomena. So down here, when we do our topic summaries, we're able to edit these. We use a language model called GPT-3 to help reduce the language and reading level and take jargon out. But then we still have someone who looks at them and says, does that make sense? And sometimes it does, and sometimes it doesn't. And that's okay. The science continues forward, and we're always sort of thinking through ways that we can improve the way that we extract the semantics from what we have. And we actually have an SBIR in to improve sort of like the quality of the hierarchy of clusterings that we pull from.
Okay, thank you. I appreciate it.
Looks like you have one more question in the chat and another minute or two if you want to answer that before we shift.
Hey, tell your hey, thanks, Monica. Hey, tell your friends. I mean, like, there's part of, I guess, the dissemination process that like just comes down to like marketing. And like, I'm a recovering academic. I stink at at marketing. I need to hire someone to do marketing for me. So hey, just, you know, play around with it. If you like it, great. If you hate it, that's also great, because ultimately, like, you know, if I had like a vision, and I do, like, I want people to be better able to engage with the primary scientific literature. I want people to feel comfortable to do this. And it's one thing to help you, like help us academics, like, oh, well, we're able to sort of work through this a little bit more efficiently, or get a grad student to do it. But I'm more interested in the parent of a kid with autism, or, you know, the spouse of a woman with breast cancer, or the child of a parent with early stage dementia, who has an urgency to learn about this stuff, not from like a ghoulish perspective, because, like, you know, profiting off someone's pain sounds terrible, but rather, how can we help them when there's certainly that motivation to engage with what's out there and trying to be on top of it? Can we make it easier for them, and can we remove the barriers towards access? So, like, that's why I sort of titled this talk like Open Science. Like, there's a lot more that we can do and will do to sort of like bring in more of those open science like methodologies into this. You know, if I had my druthers, you know, we would just release it totally free. And yet, you know, it does take time and effort to sort of keep it rolling. So, yeah, but yeah, just play around with it and let us know what you think. So sort of the lace.
Thank
That's
you so
just
much.
oh, Jessica, that's where is there a methodology to ensure the lace? So we're not we're not summarizing specific articles. We're summarizing topics. So when you summarize specific articles, that actually falls under copyright law, and you sort of run into some challenges with that, because it's a derivation of a published work. I have some like scripts I use on the side to do that for single articles, but I can't deploy them publicly. So we're not summarizing specific things, which would be super cool, but again, you're going to violate copyright then. But in terms of so we summarize the topic writ large rather than the specific article.
Thank you so much, Dr. Scacia. I'm going to move us along. We're getting into their time. So, but thank you so much.
Sure.
And maybe drop your email in the chat if people want to follow up with you directly.
Yeah, and let me find the way to stop sharing. I lost that somewhere. Where did it go? Oh, there it is. Okay. Thank you. Thanks.
So much. Thank you. Thank you. Dr. Glockner, you're going to share your screen?
Oh, I thought Dr. Linke was going first.
Sorry, I didn't know, Claire, if you just wanted to move on. So that is me. So
Okay.
I will
Okay.
share my screen
Thank you.
next. Sorry
Perfect.
about that.
Perfect.
Okay, great. Well, thanks so much for having me. I'm going to do an intro to the exercises medicine program so that everyone has context, but the majority of this presentation will be coming from Dr. Glockner. She's been doing some amazing work in our student-run free health clinic. So I'm just going to give a broad intro about what is EIM and what have we been doing to implement and evaluate it in our faculty clinics at UC San Diego Health. And then I'll turn it over to Dr. Glockner. And I'm going to try very hard to keep this around 10 to 12 minutes to give her plenty of time. So somebody please cut me off if I start going too long. All right, so I just wanted to acknowledge, of course, Claire already mentioned this in my introduction, but that this work was funded by a few different organizations, including some internal pilot funding mechanisms at UC San Diego, as well as the AHRQ. And as all projects do, and especially ones as large as this one, it takes a village to complete them. So I just wanted to briefly acknowledge this list of collaborators, and there are many more, I'm sure, that I need to update my list at some point because many people were involved in this project. So I just wanted to thank all of them. All right, so now I will start with giving that overview of what exercises medicine is, and then talk about that implementation and evaluation of it. Today, I will not be going into the results of this particular project because of the limitations on time, but we'll hear a lot about the early implementation and evaluation results from Dr. Glockner in the Student Run Free Clinic. All right, so for those of you who are not yet familiar with this topic, I feel like many of you in the disc are probably already familiar with this, but primary care physicians are very burned out. They have a lot on their plates, and this is a statistic that is often cited about the percentage of patients who recall when asked if their physician talked with them about exercise. And in those studies, only about a third of patients recalled their primary care physicians talking with them about exercise. And as I'm sure this audience does not need to be convinced about, we are hoping that a lot more physicians would be talking with patients about exercise, because from the research on exercise, we know that it has the ability really to prevent and treat really almost every chronic disease out there, and more. So we really want to try to increase those discussions in primary care settings. So we think about the way to do that across the board, since it's such a gigantic undertaking, as thinking of having a framework for addressing physical activity screening in primary care. And one of the ways to think about this is thinking about how can we design and implement a universal physical activity screening program that's quick, it's accurate, it's generalizable, it can be implemented in multiple different kinds of settings, it's actionable, it's not just something that we do for a measurement purpose, but it actually, you could act on it and you could actually measure that over time. And it's routine and expected. And we wanted to address that relationship between knowledge and behavior. So we know through mounds of research in many different health behaviors that just having the knowledge about the importance of a behavior is not enough to actually change that behavior. So we want to try to focus on how can we actually help patients to take that next step and implement those changes that they're learning more about from their physician. And we also want to take advantage of the potential we have in a primary care setting to address physical activity from a multidisciplinary lens and really think about all the different types of providers that could contribute to that discussion in addition to the primary care provider, which, as we've established, has a lot on their plate in a short amount of time. So we want to think about how can we incorporate other types of providers such as health coaches, behavioral health providers, et cetera. Fortunately, we don't have to design this from scratch because there is an initiative that has been in existence since 2007, and it is sponsored by the American College of Sports Medicine, and that is the Exercises Medicine Initiative, or EIM. And that was initially started in the Kaiser system and it has since been implemented across, I think last count, maybe 40 to 50 different countries across the globe, hundreds or thousands of health systems at this point. So what we wanted to do at UC San Diego was to implement that, but also to do it in a systematic way where we could really track, what are those adaptations that we're making from an implementation science perspective, and how are we tracking what kind of an effect it might be having on our physical activity levels of our patients. So the exercises medicine program, as it's designed, really is very basic in principle. It has two very quick questions that patients answer that are self-reported that can go right into their EMR. And those two questions are, how many days per week do you engage in physical activity, and how many minutes do you engage at this activity? And then those two numbers are multiplied together to generate a total minutes per week. And if the number is 150 minutes or greater, the patient is meeting physical activity guidelines as set forth by multiple governing bodies. And if they're under 150 minutes per week, they're not meeting those guidelines. So this is how it looks in our health system and in the EPIC system at UC San Diego Health. So these questions that I just mentioned, the PAVS questions, are found in our rooming tab. So that means that the person that's usually responsible for entering that information is the medical assistant. Fortunately, we also now have a lot of different initiatives that have taken place in the context of UC San Diego Health that have really put forth e-screening, e-screening and self-report kinds of methods and tools to help the patients to actually complete those questionnaires before they even get to the clinic to, again, offload some of that burden on all of the medical providers. And then from there, a whole cascade of things happens automatically. So I know this is a very busy slide with lots of screenshots from Epic, but basically just demonstrating that as long as those 2 questions are entered into Epic, all of these things happen automatically. So the patient receives a diagnosis of adequate or inadequate physical activity and their problem list as well. The physician gets this banner reminder that says EIM completed, please add .eim to your note. And if they type .eim, then they get these options here and they can select which one that they chose with the patient, if they talked about it or if they didn't talk about it. That way they can document it in the patient's EMR, and we can track that from our perspective on the back end to see, did this actually happen? How often is it happening? Things like that. The patient also receives a very comprehensive physical activity manual that they have a link to in their AVS after visit summary. And this is these are some screenshots of what that looks like. And then our health coaches, they also have an option of speaking with a health coach. And if they choose to do that, our health coaches also have a very easy documentation. They have some smart phrases as well that they can type in. Really, we're going for optimal efficiency in this program to make it so that it's quick and easy and efficient, easy to do on a scalable basis. All right, so how did we approach the implementation and evaluation of it at UC San Diego? You can read about our protocol in translational behavioral medicine if you're interested. But really we had 3 specific aims. And the first was to conduct a pre-implementation evaluation of our protocol, materials, and delivery strategies, and then to actually implement it and use continuous quality improvement methods to refine it in each of our clinics as we implement it, and each clinic individually. And then finally to evaluate it from multiple perspectives, including patient, provider, different stakeholders, and healthcare systems. So our approach from an implementation science perspective, we're combining 2 health services research approaches. Those 2 are the PRISM model that many of you are probably familiar with if you've been attending this meeting for some time. And then the learning evaluation model, which you may or may not be familiar with. Credit goes to Dr. Rabin for pointing me in the direction of choosing these 2 models and combining them, because that was a very big step in really defining the future of this program. And we're using real world measures to capture these kinds of quality improvement measures and also our clinical effectiveness outcomes, really relying on data from the EMR. I'm not going to go too much into this, it's very busy, but I just wanted to demonstrate how this looks. So the top part there in phases 1 and 3 that's really depicting the PRISM tool. And then the bottom one is the learning evaluation model. Again, I think I'm gonna get to my time when y'all are gonna be reminding me. So I'm just gonna skirt through these very quickly. But these are the 3 different phases. Looking at it from the PRISM perspective on the first slide, phase 1, phase 2 is going into our learning evaluation model, and then phase 3 is back to PRISM, looking at the re-aim outcomes to see how we did in terms of reach, effectiveness, adoption, implementation, and maintenance. And so that's really our overall strategy that we have followed. And then along the way, as we made adaptations, we also used the frame or the frame IS, which I think Susan will be talking about quite a bit in her presentation today, so I won't steal her thunder on that. In terms of the conclusions, like I said, I'm not really focusing on the results today due to time constraints, but so far I'll just give you a brief overview that our results to date do demonstrate that EIM can be successfully integrated, adapted and integrated into our health system. And in terms of the re-aim outcomes, we've seen very high reach and adoption. The implementation of our components has been variable. Most of them have been very high. The implementation percentage of each of those components that I mentioned, the one that we're still struggling to try to increase our numbers is that documentation by the physicians using the .eim smart phrase. That's been a challenge and a barrier, but we've been working on ways to overcome that and try to increase uptake of that component. And then the effectiveness and maintenance are, we've done some preliminary analyses, but we have a lot more to be done in terms of the effectiveness and cost effectiveness. And you'll be seeing some results coming out in the next few months from us from that perspective. Some limitations and future directions. As always, we always talk about San Diego as being this really unique place where we have year-round ideal weather that makes it easy to do exercise on a year-round basis. We are also very fortunate to be housed within an academic medical center that has multiple partnerships that might increase the effectiveness or the implementation of this particular program, such as partnerships with public health, the School of Public Health and Sports Medicine. And we also don't know, because something that you might have noticed was missing from my design is having a control group and having a kind of a baseline measure. So we don't know really how much these discussions were already happening. Now we're just able to document if they are. And then, as I mentioned, in the future, we'll be continuing to examine our data to see what we might be able to attribute to EIM being implemented in our setting. And we're going to be conducting some cost analysis models to see, what does this look like if we were to scale it on a broader basis and make sure it's sustainable from a cost perspective in our health system when we no longer have external funding. So thank you so much. I think I made my time, and I'm happy to answer, a question or two, or we might just want to save questions for the end of both presentations. I'll leave that up to really the facilitators here.
Thank you so much, Dr. Linke. Maybe it makes sense to take questions at the end.
Perfect. Sounds great. I'll stop my share and then turn it over to Dr. Glockner.
Perfect. Thank you.
Okay, great. I am just trying to get my share screen action going here. I don't think I did that successfully. Let me try that again. Share screen 2. That's why I'm masquerading as Bill Glockner right now, so that way I can use 2 screens. So I think that came up now. Is that correct?
Looks great.
Okay, great. Hi. So first of all, I'd like to just give a shout out to the team that made this happen. It was definitely a joint effort. We had our public health researchers who are attending right now, Drs. Linke and Ravine. And we also had medical school faculty. Dr. Johnson is on vacation this week, and Dr. Rodriguez is who's holding the front while she's gone. And to the students of the medical school and the public health school, Kevin was our lead from the medical school side, and Giovanna was our health coach and public health lead. So the question is how do we do this? I first appreciate the nice lead in, now with a goal to reach our patients outside of the academic medical center to answer questions about implementation science call to impact those who are under-resourced by creating community partnerships. We strive to make exercise fun and accessible for all. By supporting medical student training, we can educate future physicians on ways to overcome barriers of reimbursement and resources for PCPs serving those communities. Training, time, technology, and tools are needed, which the EIM at UC San Diego has helped us provide with tech decision support built into the EMR. Now we got to see how we do it in the student-run free clinic. This with our population without insurance or smartphones, so it's a little tricky. So the answer is adaptations are needed. We need to scale up and out from the ivory tower treadmills to join with Latinx dancers. The clinic started back in 1997 when medical students approached Dr. Ellen Beck, who is a saint and says yes to everything, that what we want to help the people who don't have insurance get healthcare, and we'd like to do something practical and hands-on. And thus it began at a church in Pacific Beach. What do the students do? Well, basically anything and everything. They function as the providers, primary care as the specialists too, with supervision on both parts by volunteer clinical faculty. The office managers, they run the help with fundraising. They deliver groceries now. They used to help serve food in the clinics, but when not in the clinics, but in the churches and their schools. But because of COVID, they now set up a grocery bag delivery system. There's also students from acupuncture schools, optometry schools, dental schools that come in and help support the other areas. And we have a team of student social workers too. And so who are our patients? You're basically only qualification is not to qualify for regular insurance. We have a few people with emergency Medi-Cal, but nobody on regular Medi-Cal. 85% are Latinx, 3/4 are women. The average age is 56. They have a closed population of 428 that on average gets seen around 350 to 375 people a year. More than half of the patients have diabetes, hypertension, and or obesity, and they lack easy access to computers or even personal smartphones. Maybe one family might have one smartphone, and so depending on the person whose needs it at the time, there's the one who has it. If they frequently lack reliable transportation and are working hard at multiple jobs, managing childcare and elder care with limited financial resources and time. So we provide work as a team to provide wraparound care compassionately and comprehensively to mitigate adverse social determinants of health with providing free laboratory radiology tests, prescriptions, got most of the clinic vaccinated on site at the churches for COVID. Specialty care comes through us too. And where do we do this? As I mentioned, there's churches, there's some schools working Monday through Friday, the afternoons, mornings, and evenings to meet the patient's community needs. We had to pivot to telehealth and managed to get donations of computers and not computers, but laptops and Chromebooks and stuff to help a number of our patients when COVID hit. So Dr. Linke already went through this, so I'll just go through quickly, just to remind people the core components of the intervention we're trying to achieve here with EIM is the PAB score. That diagnosis code will pop up, that the note gets documented, the tailored exercise prescription and manual that previously is in the ABS. We have to do something differently because we don't have computerized ABS in the clinic, and the health coaching visits done. And so how are we supposed to implement this in this setting? We built an EIM team and worked on training. The students wanted to better support patients, and so this was a student-driven idea in their physical activity needs. And so they asked the clinic director, Dr. Johnson, to reach out to Dr. Linke, who had a conversation about trying to get it started. And COVID made that challenging at the beginning, and then as time went on, they reconnected us to work together. I, as a volunteer clinical faculty at UCSD, free clinic, and so I was involved with that, and I started my master's of public health all around this same time frame. And so the students then stepped in and organized the implementation team. We had weekly meetings, sometimes bi-weekly, sometimes monthly, depending upon what the needs were. They were pre-planned and organized with students on them, clinical directors, the clinic IT staff. Shout out to Carol Eames, whose name was not mentioned earlier, but she's I call her the mom of the clinic, and she's the IT staff person and jack of all trades to solve all problems. We had health coaches and the researchers obviously on the team. And the students were trained in their class pre-implementation by faculty in general, but also Dr. Linke went in and did some talking too. And when extra training was looked like it'd be helpful, that we stepped in and helped with that also. So the challenge was trying to maintain the fidelity of EIM as done in the primary care clinics and into our clinic workflow. So how could we do it? Had to spend a lot of time thinking about clinic workflow. This is kind of a busy slide. The blues, what the students have to do, with some black being the telehealth pivots. And then the yellow is what Dr. Linke already described, which was already going on in the background as the computer was doing it. So a lot of it was shifting communication pathways from computers to in-person or phone calls. And when they would have to chat, put in the chat box to have these things get delivered into their grocery bag. But with work, we can do it, and we did it. So what did we do? We worked on clinic adaptations, were put into a structured Excel spreadsheet, and were reviewed after each agenda. The agenda was reviewed after each meeting. We planned very early and often. We had about 6 months of planning before we actually implemented it, in part due to it taking a while for the Epic team, computer team to turn on our computers because they're busy trying to fix COVID vaccine problems for the county. And then we used the REAIM guidelines to help do our planning and also our evaluation. We looked at the EPIC data extraction for the reach and effectiveness, and then did surveys for looking at adoption, implementation, maintenance with the three main stakeholders, our patients, where we had our great team of promotoras who worked make phone calls annually at a survey, and we kind of just tossed some EIM questions in there, looking at the adaptation needs. The students had class questionnaires, which made us realize more what training would be necessary to advance. We didn't have a great sense of what they had already learned before arriving, so that helped us. And then the implementation team, as I mentioned, was meeting weekly, and then after 6 months, we had used the Weiner scale assessment for looking at sustainability assessment for our evaluation of that. So what we do? Adaptations. We followed as Dr. Linke already put up the basic frame and frame IS, and frame's designed more for the actual intervention, and frame IS is for the intervention strategy. So we actually had to get a little creative, and we did kind of a blend of the two, because one of our first questions was, well, which things we're changing, a component or an implementation strategy? Because we actually had to do a little bit of both. And then the other thing is we wanted to focus on what was our intended impact. So here are some of our implementation. Here's our adaptation slides. It should look kind of familiar from what Dr. Linke just put up. Here's our 2 extra columns of the impact and which component it was. First thing we did, which was actually key to, I think, a lot of our success, was Dr. Johnson agreed and thought it was a good plan to put that .eim phrase, which we are struggling with in the other clinics prior to the free clinic, to get that put in, and she just made it part of the students' template. So the students knew that was something they're supposed to fill out, and things would happen and it wouldn't always get filled out, but at least it was there in front of them. It was harder to forget that way. We had our health coach helped do the translating for the manual, and our promotoras, and she combined worked on the health coach handouts, our tailored prescriptions, rather than being generated by the computer and handed to put on their phone in English, were translated on site into categories of people with having less than with no exercise, or as getting one type of handout. People who had doing some exercise but not at their 150 minutes would get another one, and then people over 150 minutes would basically be get a "congratulations, you're doing a good job" note. And that was actually our hardest adaptation to make clinic flow work, but we finally figured it out. The general manager also, instead of having the patients, as Dr. Linke said, self put in you could get referrals for the health coach through the electronic system. They can even now self-schedule. We weren't able to do that, so we just normally the normal clinic workflow would be to schedule appointments for specialists. So we just put the health coaches, that was an option. The exercise manual, as I mentioned before, we put into the grocery bags, and those were going out to the patients because it also had their prescriptions. So we used that kind of workflow. And then mentioned the phone survey, instead of having a survey deployed to the patients for evaluation via electronics. And as Dr. Linke mentioned, the medical students needed to act as the ones who entered the paths, the days of a week and number of minutes per day into the computer. So here's a busy slide of the tabulations of looking at the top are the different adaptations we did, and down the side are the types of what categories they're in. And then you can see here we picked out the ones that tended to be the biggest to look at a little more closely, to kind of analyze our adaptations affecting each of these, and summarize that in this next slide. So the one which was more common, the component of the implementation strategy, well, they both were fairly equal, but the facilitation aspect of implementation strategy was used the most for helping training and helping workflow, which was the main thing that was modified, was trying to make the workflow adapt. We adapted how the workflow in the clinic would go. Our nature was that we spent a lot of time working to integrate with other programs. One thing I should mention here too is the students who work in the clinic. There's a few managers that are consistently there all the time. Those tend to be undergraduates or post-baccalaureate students who have more time. The medical students might come and see patients maybe 4 times a quarter. So we really needed to have the program run well, so you could plug students would just hop in when they came, and it wasn't complicated for them to remember because they weren't redoing the same thing each time, every day or every week even. And the goal was to make it, again, better fit the free clinic. And organizational level and the clinician level were both targeted pretty equally, as was we used the word coordinating to identify it wasn't that there was an initiator and a followers, it was usually a group kind of decision. And it was interesting that it equaled between the administrator and the researcher. And it was mostly focused at the clinic unit, and our intended impact, we needed to be efficient for it to be a long-term and sustainable program. And so one thing I want to make sure I forgot, that because it was so, we planned so hard and long on our pre-implementation process, one of the things is, when do you do the adaptations? Ours all were planned and during pre-implementation. We had little tweaks we did during the thing, but not any true adaptations once we started. Here's some of our data analysis of some of the results. Here's the remember we're saying that the .eim phrase, by putting that in their template, almost 90% of the time that was documented. This is our 3-month data. So it was shortly after as people's name, but still you can see the patients were getting the referrals to health coaches fairly well. And then the annual survey also happened around this 2 to 3 month time frame, just because that's when it was. Real world. You do your survey when the clinic can do the survey. So, and the promotores had it teed up. But the patients found that it was very helpful, or very helpful. And then the one thing is we're a little confused. We looked at the unsure qualitative answers, and it was more that they hadn't really had a long enough time. They'd only found out about the exercise health coach maybe or maybe not had talked to him yet, and so hadn't tried to do the activity yet. Here's some of the PAVS results and the demographics. This basically is showing that the group that we really looked at, where we're doing most of our data analysis on, were ones that had 2 PAVs, so we could compare pre and post, since we really had no other controls in the system, was just self-control on the patient with whatever outside forces may be at the same time, or whatever timing was random. But as a result of this, what we were happy to see is that the groups were all pretty equal. The only group that was a little that was not equal is there was a higher percentage of patients who had only had 1 PAV score who actually did the health coach visit. That group, that'll come up a little bit later about our health coaching. So that the people with fewer visits had more health coach percentage-wise visits. Here's that kind of highlighted there. Overall, we're really happy to see that we had our patients exercising 22 minutes on average per week more than they were on that. Remember, looking at the PAVS 1 versus the PAVS 2 time points. Is pretty equal between males and females, not quite statistically significant when they're separated, statistically significant when it's combined. The thing, this is where the health coach is kind of interesting, is that the ones who got the health coach call, their second PAVs actually went down, not significantly, but again, we'll come back and talk to that a little bit more detail. And so here's another graph that kind of represents this. Although this is complicated, the timing of the call was assessed to check to see what the PAVs was on either side of a health coaching visit. So that for people who had a health coaching visit between 13 and 45 days and had a PAV score on either side, were in this 30-day category. And same thing for the 90 days, that was set up at days 46 through 120, and 6 months was at 121 to 180. So that meant you had a PAV score on either side with a health coach visit between. And you can see here's the PAV scores on the y-axis, and they're on the 120s to 130s for most overall. This blue is the all group, so that'd be the main group to be taking a look at. But because we were looking at this health coaching, that was a little bit different. Surprisingly, the health coach group had a decrease in their PAVs go along. At 90 days, they were more neutral. And this is the time frame, as you can see down in this table. This is when there was statistically significant improvement. At the 90 days was the most, had the highest N and the most statistically significant improvement. And it was where the coaching was neutral. And then by the 180 days, it was, you can see the split, the green bar being the no health coaching group and the burnt orange one being the health coaching group. So that overall, the improvement in all groups except for the health coaching group. But one thing also to notice, if you just kind of look at the baselines are 120 to 125 at the beginning, they go up. So the baseline is starting higher. So the overall trend of being in the clinic and being exposed to EIM was in the positive direction. So the demographics and disease status were consistent throughout the subsetting of the data. And the question is were the patients who completed the health coaching call different with than those that were only represented in that group that only had one PAV score? Because that's why there may be a difference. Maybe there was, if this isn't broken down by timing, it's unclear. Working in implementation science with real situations without the ability to have a strict control group limits the statements of causality. So you can see that the things that were a little bit more controlled is when pre and post surveys for students, talking to the patients, getting their physical activity totals up. But maybe the health coaching did, maybe it didn't help. Not clear at this point. Looking at the last aspect of REAIM, we triangulated data from our 3 key stakeholders purposely and attempted within real world constraints to examine the success at different points in the implementation process. So let's first look at the students to see how successful this implementation was. Well, this graph shows their perceived barriers to talking about exercise. And the light blue is the pre implementation numbers and the dark blue is the post. So you can see here that the post one for time actually went up. So they saw time as a bigger barrier, perhaps because they learned more and they wanted to take more time to talk to the patients. So that was now a barrier. But if you look at the rest, see on all the other ones, the light blue is above the dark blue, except for in this other group where there's some qualitative comments. But really real noticeable one here is, look, the dark blue we went from for like training before the EIM was implemented, and before the training, 66% of the students felt they didn't know how to talk about exercise because they weren't trained. And after 6 months, only 15% felt like they didn't have enough training for that. This slide is focusing on the patients in their survey. Were asked to ask what do they remember? Do they remember the exercise discussion? Well, up above 80%, which is correlated well with the students' note being documented. The health coach, they remembered the health coach being offered, and not as many completed it. Also, this was early. This survey was done at around like 2 to 3 months of implementation. So not everybody would have had time to complete the health coach visit. And then the manuals, we were really only able to check the manuals at the end. There's a process of getting the right amount of manuals in the right locations, but we eventually had delivered, the patients remembered receiving a manual 65% of the time, and we actually had distributed 51% by the end of the 6 months, or 8 months actually. And then we talked to the team and asked our implementation team what they thought about the implementation process and using the Weiner scales of acceptability, appropriateness, and feasibility. And these are scored up to a scale of 5. What you're seeing here are the numbers of responses. So there are 16 members. So the highest score you could get would be 5. The highest score was for acceptability was 4.5. And the second was appropriateness. You can see that up here, everyone, all 6 people in the team all felt it was an appropriate intervention to have. And then feasibility was at 4.29, so still was, above, significantly above a neutral of 3. But there were in this one a couple of the team did feel it was neutrally feasible. And here's another look at comparing the patient's recollection versus the EMR. So you can see the first 2 here are about the EMR being recoded at 2 time points. So the darker blue in this one is from after about 3 months of it, 2 to 3 months of the implementation, and the lighter blue is after about 6 months. So not surprisingly, with time, students weren't as thorough. This is up to almost 90%, but they still were staying above 60% without having frequent reminders, or they just the protocols that they'd set up and were running. And you can see that here the exercise was being the patient. This is that patient EMR correlation, and the health coach. Here's the manual that I was saying that got delivered more at the end. The patients didn't remember it as high as they had gotten delivered, but on that there wasn't tight supply control on that. In that I'm sure there's some, we all know that there's some patients who got 2 manuals and other patients who didn't get any. But at least 51% got out into the hands of people in the first 8 months. So overall, looking at adoption, implementation, and maintenance, how did we do? Well, overall, the students overcame their barriers, but except for time, so they felt much more confident. There's another rating on confidence, and they felt that their confidence improved dramatically. Did the patients recall the support of the physical activity? Yes. They appreciated and recalled it and found it helpful. How successful was the implementation process? Well, the implementation team found that this intervention was something that was acceptable, appropriate, and feasible to implement and maintain, which is what our goal was. Working with the community partners optimized the implementation success, but also reduced ability to control for variables to preserve the efficiency of workflow and to maximize equity for all to achieve good reach and adoption. So can the IM work? Yeah. This is working right now, and there was a little drop off after 90 days, but the exercise scores still were continuing to go up, and the physical activity was above baseline. We'll hope to do some follow assessment later to give a more long-term viewpoint. So back to just a final kind of quick discussion review before we have opened up for questions. We did kind of a modified frame IS to include both the components and implementation strategies. We worked hard to focus on fit and patient workflow, but in the pre-implementation planning was the main time, was the only time we actually did adaptations. And by doing so, we think that was in part due to the community co-creation of it, and that we had actively been that the community actively wanted a program for exercise. So the REAM principles guided us well through the pre-implementation planned adaptations. Felt that our fidelity was maintained. We proved some clinical effectiveness. The secret sauce was that, as I said, they asked for help and wanted to help us create it. The students remembered to enter the scores, did their documentation. The patients improved the exercise by 22 minutes. So in simplified form, we had 2 goals. The students learned things and the patients exercised more. And that was the goal. And it so far has been working. We'll have to look for its long term. We looked at our mixed methods and multiple stakeholders at the patients improving their physical activity, the team feeling that it's an efficient thing, that the clinic could maintain this, and the students got their training. So we're currently now kind of in our maintenance phase, and we'll hopefully know more in 6 months if it's still going well. And but we assume that with the acceptability, appropriateness, and feasibility levels high, feel good that it can continue. And as Dr. Linke already mentioned, there's uniqueness of San Diego, but particularly this population is not highly generalizable with its uninsured, primarily monolingual Spanish patients and students as the doctors is a pretty unusual combination. However, this has been also already educating future doctors. Our student, Kevin Deo, led the final wrap-up session for the students in the free clinic presenting the data. He then presented it to the national conference, got very good reviews, and people have been asking for our manuals and how we did it to get more guidance for them to try and put it in their medical schools system too. Yeah, data collection is challenging. Real world setting is messy. The lack of controls in general and specifically with timing have to do with surveys when the community partners can do them. There aren't control groups. Manuals can just kind of be missing for a few days. They get behind something and students are busy. We aren't able to say with clarity what generalizable this be, but it seems to be at least a good start because we did adaptations. So one of my questions is, how do you define an adaptation? Because that was a little bit of the challenge. Is it how far away from the core, not from the core, but from the exact core, does it become an adaptation? And then when does the adaptation actually become too far and stray away? And that seems to be a fine line. So as I mentioned, we're going to try and do the surveys a little bit for a longer term assessment, and looking forward to that patient summary. The current medical students are in there doing their step thing now, and then they'll go off to third year and disappear for a year, and then most of them can actually come back and work in the clinic again as fourth years, and we'll try and survey them again at that point. More real world implementation science needs to be done in a lower resource population, especially those populations on the other side of the digital divide, while also adapting to cultural and language nuances. So the key to equity is co-creation of the implementation and of an intervention and focused on planned pre-implementation adaptations, and hope that more studies can occur in the Hispanic population. And open up for, I was trying to get done by 3:15 and I did it. Any questions? Like I said, one thing would be to discuss would be talking about adaptations. What makes a adaptation? I see the chat stuff. Should I probably stop sharing my screen now, right? Okay, let's do that. So here we go.
Thank you so much, Dr. Glockner and Dr. Linke. This is such an awesome body of work, and so much tracking and data collection clearly went into this project. So wonderful job. We have 15 minutes, so we can invite questions now. That sounds great. Does anybody have? There are a couple of questions in the chat. I think Dr. Linke, were you able to address most of them?
For some, okay, there we go. I can see the chat now. Okay, I was trying
Yeah, I think I addressed the ones that came up in the chat, but definitely happy to entertain additional questions.
Oh, I'm sorry if I missed this, but is this continuing on, or was that just part of the?
Yeah, no, it's ongoing. All the students are doing their. I mean, I teach there at least twice a month, and the students are putting in the scores and the manual. That's why I literally physically counted the manuals last Thursday, and they're giving them out, and they know how to reach us so that we can give them more manuals if they need more manuals, and they get all the stuff's going in the grocery bags. There's now about a third of the time the patients are being seen on site. And so that stuff is getting handed to the patients in person too. So it's been that was the other one of the things where I was thinking about the health coach thing is in the timing, because, the COVID lockdown and were you working or were you not working? Did you get laid off or were you working extra as a frontline worker? That's a very complicated layer of the external environment. Did that have any impact in these? We picked the days because those are the traditional timeframes in which you would look at seeing effective exercise. But the environment changes a lot, and we did not do anything that was tied by looking exactly at when things were open or not and when people were going back. And so that may be one of the other things that makes that data a little messy, as I said.
Great, thanks.
And I'll add just something to that, Sarah, as well. So basically the EIM program will now live on as just a clinical initiative. And so, and that kind of was, I guess, dictated by my K award. And so now that the K award has ended, now the program lives on in both environments as a clinical initiative. We are going to finish up the evaluation in both, but from then on, it study any longer. It had already been implemented as like a universal screening program anyway, but we were, thinking of it as an implementation project, and now it's just part of like the fabric of primary care.
That's great.
Yeah, and the thing that actually Dr. Linke got all really nicely set up too was the health coaching is the one kind of, once you got the protocols going and the computer does its thing, there's not a lot of extra resource that need to come in on a regular basis, except for the health coach. But she's done a great job with linking up with Point Loma. Nazarene has a, I don't know if she can tell you exactly the name of the program, but it's a program where health coaches get trained to get licensed for being health coaches. So they've been serving their internship hours with us under her direction. And now there's another professor at UCSD that is taking over the role as being the mentor for that. Is that just going to be part of what they do, is mentoring those interns, and it looks like there's going to be an okay pipeline to have at least one of them be bilingual, bicultural for the free clinic population. And it'll also be an opportunity because occasionally, because I did health coaching for the regular faculty clinics when I first, right the summer before I started my MPH, and there would occasionally be patients that spoke Spanish. And I would try and do my Spanish, but my Spanish is by no means bicultural, bilingual. And so they'll have an effective resource for people who need to speak Spanish when necessary, which isn't that often in the regular population, but that's 95% of the population we're dealing with in the free clinic.
In terms of resources for maintenance, I guess what else is involved? So you have these linkages with the health coaches, but do there need to be sort of ongoing meetings to like refresh and do like other trainings? Or I'm curious, Dr. Linke, from your perspective, the maintenance resources.
Yeah, so that's definitely, keeping people refreshed, as you're saying, and as new people come in, making sure that knowledge transfer happens so that they're trained up. And we are already seeing that happen, that kind of fade happen a little bit, because we recently did some qualitative work in our primary care clinics on the UCSD faculty clinic side, and found from our interviews with some of the newer medical assistants that they were not as aware of the different components of the program. And so that keyed us into, okay, we need to formulate a way to have regular ongoing trainings, because they're very busy and a lot of things can be dropped. And so absolutely, that's something that we've been working on. There's a counterpart that I have, Dr. Laura Sudano, who is a integrated primary care provider, and she has graciously offered to kind of help that transfer continue to go as I continue to be less and less involved. So hopefully we can make sure we have a system in place to make sure it doesn't get lost in the system.
And in the free clinic system, Drs. Rodriguez and Drs. Johnson both know all, they are the part of the co-creation team. So that's already kind of like built into their system. And because it's a student run clinic, they already have to deal with the fact that students, graduate, right? And so that's why the workflow and protocol was so important, because that's what makes the system work, is to have an easily, where you can modularly put students in and out, and each student, as they're leaving whatever role they have, their job is to train the next student coming in. So, Kevin, the student who's the lead on this, is a second year. He still be at the school for 2 more years. And so the hope would be he would then train somebody to work as an EIM kind of lead. And then I'm still teaching there. So I certainly am around and available to do if they, and Dr. Linke, I'm sure if Dr. Johnson said, hey, we want another session, in one of the classes, I'm sure Dr. Linke would probably go in and do it. If some reason she was busy, I could do something like that too. So there's a little bit, there's slight touches in there, but it's really the way that the clinic is set up as a clinic for medical students and run by them, that that's how things get sustained. That's part of the whole culture of the student run free clinic.
Thank you. Are there other questions? All right. I have one more that I'm going to ask. I had a lot of different questions. It is interesting to think about like how much you can capture related to adaptations. And like you were saying, Susan, just like what is like important to capture. You could essentially write down everything. Like if you change the flyer color and the font and like, does that count as an adaptation and should that be tracked? Like from your perspective, how did you set it up to understand what to document?
Well, I tended to over document because I'm a novice in this area. So I would always be going, now I think I thought of another adaptation. Like this one's, I like this one. And so it's like, well, no, see the core element really isn't changing, but it's, you know, the stuff. So, but then there'd be others like, well, yeah, that's why I asked the question. I'd be interested to hear, you know, some people in the audience, I don't know if Nicole's still in the audience, that have a lot of experience in these areas, is how do you hit that sweet spot? There's a sweet spot because and it's a continuum. It's not categorical. So but you have to suddenly call it an adaptation. So how much, you know, the color font isn't cut in I didn't even try and document that. But, you know, did the pandemic, the fact that we had to teach things differently in the pandemic, I kind of thought that would be one. But then as Dr. Linke mentioned, yeah, the telehealth thing we had to do in the main clinics too, and the whole adaptation side that I was looking at was what was needed for the free clinic. Well, they did the same thing in the faculty clinics by going to telehealth. So it wasn't an adaptation because it was for EIM in the big sense, but not in the EIM in the small sense, just for the free clinic. So things like that were, you know, discussed. So, and so there, I mean, I think I had 12 and then it ended up being pared down to 8. And so, and like I said, I'm a novice in the area. So that's why I would love to hear if anybody else still on the line has any comments about how they define that.
Yeah, I will just make one more comment about that. And I'd love to hear other perspectives. This is definitely an area that I find fascinating as well, and what kind of counts. And I think this is something that, you know, we've also taken back to Dr. Rabin. And I think that one thing that I think that for me, coming in with the implementation science and the quality improvement models together, I think my view is, I think Dr. Rabin said in the chat too, was a very pragmatic approach to what was an adaptation to the core components of EIM. And then I considered other things kind of a quality improvement cycle. And I tried to think of it as like, does this actually, you know, change and would like the fundamental components of the program, and would we send this out to say all other future EIMs should make this adaptation if they have this characteristics, or is it a, you know, quality improvement kind of cycle improvement? So definitely curious to hear what other perspectives are on this, because I don't think that there's probably a right or a wrong answer on this, but perhaps others have opinions on it.
Worshika, what do you think? as our expert in adaptation.
I don't think so, Claire, but I appreciate you asking. We had so many good discussion with Dr. Linke and also Susan about this, but also other teams. And I think I was very excited to have this study use a pragmatic approach and really be very minimalist in what they identify as an adaptation, because most of the other studies where I work, we are just too inclusive because we don't know what is really important. So we are still very inclusive. And I just put in the chat, we have been playing around with this definition that anything that has a potential to impact the implementation, you know, broadly reach, adoption, implementation, etc., or the effectiveness of a program, or anything that might change how others scale it in their settings. So that's one way, but it still doesn't help. So I love the question. I enjoy this being more pragmatic in this particular study, and I would love to hear from others.
Any other thoughts? I'm curious also, like, how do you decide what is consistent with fidelity? So like if you're tracking adaptations to your core components, when is it too much? And when is it getting away from fidelity? And is there processes for that you need to put in place to figure that out?
The one I
Yeah.
think we were most challenged by, I'll let Dr. Linke explain the nuances of it, was this handout, because it was definitely it was definitely a struggle, because there's no way we could really do it exactly per patient, because of it'd take too much time to have that written out exactly the way it was written on that. And so we feel that the sweet spot was what we ended up with, was the adaptation of tiering it into those 3 groups of the people who are no exercisers, going past the recommended, and anything that weren't quite where they needed to be. But then there was definitely discussion, because the workflow was challenging. It was challenging for the students to get the right one and the right, first of all, it was like, oh, well, we don't know enough Spanish, so then we're going to color code them, and then we just put part of it in English so they could know which handout went into which bag, they could quickly look at it and get it in the right bag. And they had to remember to put it in the chat. So it took a while to do that. So that at one point we'd even contemplated doing a universal handout that just said, hey, everybody do this, because that was, from a workflow standpoint, easier. But with enough time and energy on trying to do the tiered one, they finally like, well, actually, we kind of do have it going okay now. So it's okay. We can live with it being this way. But to me, that was the one that was the biggest challenge one on it. And I'll let Dr. Linke, she's more of an expert on it than I am.
I'll just wrap up real quick because I know it's time. But yeah, I think that the other interesting component to this particular study with thinking about adaptations is that, we were not, as I mentioned, the original creator of EIM, and that was, done long before us, and that has been implemented widely. And I think with the core components, there isn't a one, universal way to present this prescription. There's not even, a one that's available. It's every system you could come up with your own. And so there's not really a standardized one that everyone is using. And so from there, it kind of, to me, says, well, as long as you have the core component of recommending more if you're under the recommendation, or under the 150 minutes per week, recommending maintaining if you're above, then you're getting the same message out. So I think that was one of the deciding factors for me, that we weren't the original creators of it. And so therefore everything after us is not an adaptation. So that's just one thought about it as well. Thank you so much. Excellent presentation, Susan, and thanks so much for inviting us.
Thank you. Thank you so much.
Thank you very much. Take care.
Bye.
Bye, everybody. Take care. Thank you.